聞こえます? Can you hear me? あれ聞こえない?
聞こえます、聞こえます。
聞こえます?
はい、どうぞ聞こえてます。
はい、大丈夫です。
はい。
OK。
はい。
もうやる時間じゃないですか。
はい、もう始めると思います。
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. My name is Dr. Putri. It is a wonderful and precious chance for me to be your master of ceremony in this sunny afternoon on 25th of June 2022 in our big event, third webinar international with public liver disease with medical students, young doctors, and doctor students. Cooperation Japan's Medical School International Collaborative Assembly and Association of Muhammadiyah Medical and Health Education operated by Faculty of Medicine, University of Muhammadiyah Malang. First of all, let's say thanks to Allah Subhanahu wa Ta'ala who has been giving us guidance, happiness, healthy, and mercy so we can attend and participate in this event without any obstacle. Praise and salutation upon our Prophet Muhammad Sallallahu Alaihi Wasallam, the best figure of this universe, the person who was able to save us from Jahiliyah era. To the Honorable Professor Ito, as President of Japan's Medical School International Collaborative Assembly, the Honorable Professor Dr. E.M. Sutrisna, Master of Health, as President of Association of Muhammadiyah Medical and Health Education, the Honorable Professor Yamashiro as Vice President of Japan's Medical School International Collaborative Assembly, the Honorable Professor Yamashiro as Vice President of Japan's Medical School International Collaborative Assembly, the Honorable Dr. Medi Setiawan, Internist and Fellows of the Indonesian Society of Internal Medicine Asjin of Medical Faculty, University of Muhammadiyah Malang, the Honorable Professor Dr. Joni Junaidi, Internist, Consultant Tropical Infection from Department of Internal Medicine, Faculty of Medicine, University of Muhammadiyah Malang, as first speaker, the Honorable Mr. Ken Sato, Medical Doctor and PhD, Associate Professor from Department of Gastroenterology and Hepatology, Gunma University Graduate School of Medicine, as second speaker, the Honorable Mrs. Maki Tobari, Medical Doctor and PhD, Associate Professor from Department of Diagnostic Imaging and Interventional Oncology, Juntendo University Graduate School of Medicine, as third speaker, the Honorable Mr. Koichi Wakawano, Medical Doctor and PhD, Associate Professor from Department Surgery, Nippon Medical School, Chiba Hokuso Hospital, as fourth speaker, the Honorable Dr. Aryani Vindya Putri, Ophthalmology from Department of Ophthalmology, Faculty of Medicine, University of Muhammadiyah Malang, as moderator, the Honorable Prof. Takashi Yashiro, Medical Doctor and PhD, as co-moderator, the Honorable Lecturer at the Faculty of Medicine at University of Muhammadiyah Malang, and welcome to all participants of the seminar present today. Ladies and gentlemen, before we begin this webinar, let us pray together. My God, Mercy is beneficial for all of us, and this event can run smoothly. Pray based on individual belief begins and done. Okay. Happy audience. On this occasion, allow me to introduce you to today's agenda. The first is the opening, which we previously had read together. The second is welcoming speech. The third is the core webinar with 4 speaker and moderator, question and answer session, also discussion between speakers. The last is the closing. Now we invite Professor Ito, as President of Japanese Medical School International Collaborative Assembly, to give a first welcoming speech. To the Honorable Professor Ito, time and screen are yours.
Thank you very much, Dr. Putri and the distinguished guest, and also the professor in Indonesia. We are very much honored to be here. And also, my name is Dr. Eto, Chairman of Japanese Medical University International Assembly, so-called Jamaica. I am very much pleased to say hosting on the third international webinar conference between Jamaica and also Muhammadi Medical University. The topics of this third conference will be the discussion on the liver disease. This seminar is a great opportunity to discuss about these topics, and holding of such a medical seminar between Indonesia and Japan is a great opportunity to foster the young doctors and also researchers in both countries. I am sure that this medical seminar between Indonesia and Japan will contribute greatly to the development of young doctor and researcher in both countries, as well as to medical exchange between two countries. Finally, I would like to congratulate you on such a success of this medical seminar. Thank you very much for your attention. Thank you. Okay.
Okay, thank you, Professor Ito. The second is opening remarks from President of Association Muhammadiyah Medical and Health Education to the Honorable Professor Dr. E.M. Sutrisno, Master of Health. Time and screen are yours.
Thank you very much. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirabbil alamin. Hamdan syakirin, hamdan yuwafiqu wa mazidah. Ya Rabbana lakal hamdu, ya Rabbana lakal syukru, asyhadu an la ilaha illallah wa syarika lah, asyhadu anna Muhammadan abduhu wa rasuluh. Honorable Professor Ito, President of Japanese Medical School, Professor Takashi Yoshiro, Professor Dr. Johnny Junaidi, internist, Associate Professor Ken Sato, Medical Doctor PhD, Associate Professor Maki Tobari MD, PhD, Associate Professor Wici Kawano MD, PhD, Dr. Medi Setiawan, President of University Muhammadiyah Malang, all participants, ladies and gentlemen, first, I'll pray to Allah Subhanahu wa Ta'ala for such blessing we can attend this webinar with tema liver disease. Salawat and salam to our Prophet Muhammad SAW. Ladies and gentlemen, let me introduce myself. I am Sutrisno, medical doctor, President of Associate Muhammadiyah Medical School in Indonesia. Today, UMM, Universitas Muhammadiyah Malang, carry out this seminar as an implementation of Memorandum of Understanding between Association Muhammadiyah Medical School Indonesia with Japanese Medical School, signing in 2021. And ladies and gentlemen, Professor Ito, Professor Takashi, Professor Yoshiro, for information, APKKM, Associate Muhammadiyah Medical School in Indonesia consists 12 medical faculty. So we are very powerful in Indonesia. And this next time, I hope the implementation of MOU not only webinar, not only seminar, but also maybe research collaboration, teacher exchange maybe, and substance exchange, and maybe student mobility. I think that's all. I hope this webinar successful and running well. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Professor Sutrisno, for your speech. The next one is opening remarks from Vice President of Japan's Medical School International Collaborative Assembly to the Honorable Professor Yamashiro. Time and screen are yours.
Yes. Hello, everybody. Welcome to the international webinar on liver diseases. I'm sure you learned the basic and important medical knowledge from well-known doctors in Indonesia and Japan. Please enjoy the lecture. Thank you.
Thank you to Professor Yamashiro for his speech. The last is opening remarks from Dean of Medical Faculty, University of Muhammadiyah Malang, to the Honorable Dr. Medi Setiawan, Internist and Fellows of the Indonesian Society of Internal Medicine. Time and screen are yours.
Thank you. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. Thank you to everyone for being here today at this event. It is an honor to speak on behalf of the organizer. Let me begin by giving you a warm welcome to international webinar with the theme liver disease, what the medical students, young doctors, and doctors need to learn. Before we get started, I would like to express my appreciation to all committee who seriously helped us make this seminar come true. And thank you very much, Prof. Eto as President of GMICA, Prof. Takeshi Yashiro as Vice President of GMICA, and Prof. Dr. E.M. Sutrisna as President of APKKM, and Dr. Wawang as Dean of Faculty of Medicine UHAMKA, and also to all speakers and participants. We could not have done with it without you. We all know that in the past, we got some cases of hepatitis of unknown causes. The situation also caused a panic in the world of health in several countries. A wide variety of liver disease requires special attention to treatment. Therefore, on these occasions, let's learn together with experts who will convey their knowledge of liver disease and what and how it can be managed holistically. I apologize if the implementation of this event is still not perfect. I'm sure that today will be fun and full of learning. I hope that event like this can be carried out regularly and with more exciting themes so we can continuously develop sciences. Enjoy this event and have a nice day. Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Medi, for his remarks. Let us start to the core event webinar with 4 speakers and moderator. But before that, we can activate the camera. To all participants, please activate at the camera.
Okay, we would like to take pictures together. Please open your camera. Maybe operator. You can count. Okay. Smile.
Screen 1, 1, 2, 3, and cheers. Okay. Screen 2. 1, 2, 3, and cheers. Thank you. Next screen. 1, 2, and 3. Okay, thank you. Okay, done. Thank you to all participants. Back to webinar. The webinar will be directly guided by a moderator. To Dr. Aryani, time and screen as yours.
Okay, thank you, Dr. Putri. Assalamualaikum warahmatullahi wabarakatuh.
Salam warahmatullahi.
Good afternoon in Indonesia and good evening in Japan. Ladies and gentlemen, dear attendees, our honorable speakers, the presidents of CHIMICA and presidents of APKKM and the committee Welcome to the third international webinar hosted by Medical Faculty of Universitas Muhammadiyah Malang with the collaboration of EPKKM and Jamaica. First, please let me introduce myself. My name is Aryani Vindaputri, but you can go by with just Aryani. I'm from Ophthalmology Department of Medical Faculty Universitas Muhammadiyah Malang, who will guide this webinar as moderator for the whole session. And besides me, there's also Prof. Takashi Yashiro, who will be the co-moderator for today and supervised me and helped me to communicate with the speakers if there are some troubles. Hello, Prof. Yashiro. Okay, first, today we will listen to 4 great topics about liver disease, what medical students, young doctors, and doctors need to learn that will be presented by our 4 great speakers from Indonesia and Japan. From Indonesia, we have Prof. Joni Junaidi. From Japan, we have 3 speakers, Dr. Ken Sato, Dr. Maki Tobari, and Dr. Yoichi Kawano. After our 4 speakers done with their topics in the last session, there will be sharing discussion or panel discussion to discuss the questions of, or our speakers can share their experience in their centers maybe. Okay, without any further ado, the first presentation will be delivered by Prof. Joni Junaidi, internist consultant in tropic infectious disease, who will speak about general status of liver disease in Indonesia. And for our information, several days ago, Prof. Joni got injured and already had a surgery, but we are so grateful that he could attend this meeting during his recovery. During his recovery time. I will greet Prof. Joni first. Hello, Prof. Joni, how are you?
Hello, well, Assalamualaikum warahmatullahi wabarakatuh. Thank you very much, Mrs. Moderator, Dr. Aryani.
Thank you. We hope you get well very soon, Prof.
Inshallah.
Amin. Okay, before Prof. Joni deliver the presentation, I will read briefly of his curriculum vitae. Since he had long experience and our short time, allow me to read briefly of his curriculum vitae. Professor Joni Junaidi, internist consultant in tropical infectious disease, was born in East Java, Indonesia in 1945. He became professor in 2007. He also a lecturer in medical faculty of Universitas Muhammadiyah Malang, also a clinician in several hospitals in Malang, and now he is a head manager or director in Universitas Muhammadiyah Malang Hospital. To all audience, if you have any questions, you can ask to Prof. Joni directly by raising your hand, open your cam, open your mic in the discussion session right after Prof. Joni finished the presentation, and or you can write down your question in the chat box, and I will read it, and Prof. Joni will answer it right after he finished the presentation. Okay, Prof. Joni, you have 30 minutes for presenting your topic. Please, time and screen is yours.
Thank you, Mrs. Moderator and Mr. Yoshiro as a co-moderator. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Konnichiwa. I say to say thank you to Professor Eto as the president of Japanese Medical School International Collaborative Assembly. I want to say thank you to the Vice President of Yamashiro, and to say thank you to Mr. Professor Dr. Sutrisna MKes, the head of Muhammadiyah Surakarta, and then to say thank you to all the participants, to say hello to my colleagues, Professor Sato and Professor Tobari and Professor Kawano, that will be as the following speakers. That is why I am here because of our dean. Thank you very much, Dr. Mehdi, that I get the opportunity of Dr. Rupi to have discussed with the international, the consultant, all the speakers as international speakers. That is why first I want us to be as a speaker with the title of General Status of Liver Disease in Indonesia, but unfortunately I haven't found all the data yet. That is why I want to change my title of my my paper as with the title of Clinical Pattern of Liver Diseases. Patient admitted in General Hospital Muhammadiyah University of Malang. I think the data will be connected with the second, the third, and the fourth speaker. Okay, first, introduction. Liver diseases as a derivative of liver function. It is acute or recurrent progression. Secondly, the etiology. We know there's many etiologies. The toxins, the alcohol abuse for a prolonged time infection, the hepatotropic or the non-hepatotropic, the autoimmune diseases, the genetic and the metabolic, hereditary, pregnancy-related. Presented ischemic and vascular and miscellaneous. That is why we see, we have a look to the etiologies. The etiologies is so many etiologies, variety, so many variety that our liver is so easily abused by all these etiologies. Secondly, the non-alcoholic hepatocytosis will be discussed by the third speakers. We have 37% in the adult population in the United States. It is characterized by accumulation of triacylglycerol tacrich, and also with the absence of inflammation of liver injury. If there is an inflammation or liver injury, that is a non-alcoholic. The chronic liver disease is usually common as a clinical condition, and the focus is done on the common etiologies, and the clinical manifestation and management will be soon. The underlying mechanism of fibrosis, the early stage of cirrhosis that at the cellular level, because of the recruitment of the stellate cells that produce the fibrosis, fibroblast, and resulting of fibrosis. At the end of this chronic diseases, there will be a cirrhosis as a final stage of a coronal liver disease that results in the disruption of liver architecture, the formation of widespread of nodules, vascular organization, neoangiogenesis, deposition of an intercellular matrix. NSRH is a non-specific reactive hepatitis. Usually is a common we find in the clinical patients. Is characterized by inflammatory infiltrate in portal areas and hepatic parenchyma without hepatocellular necrosis or apoptosis. That is why the non-specific reactive hepatitis usually show an SUT and SGPT, ILT and AST increasing. In the period of pandemic COVID-19 associated with liver injury, there is any liver disease and a liver damage occurring during disease course and treatment of COVID-19 patients with or without a pre-existing liver disease. Includes a broad spectrum of potential pathomechanism. There is the virus directly cytotoxicity effect, the CPE, that provoke the viral replication of SARS-CoV-2 in the liver. And secondly, the other mechanism is immune-mediated liver damage. It is because of our immune response that so severe inflammatory response and systemic inflammatory response syndrome will be done in COVID-19. Epidemiology. We want to see about what is happening in the global hepatitis prevalence. Hepatitis B, it is in various by country. Year 2019, 296 million people with chronic hepatitis B. The prevalence is 3.8%, with 1.5 million new infection, with 820 deaths. But while the hepatitis C varies by country, year 2019, only 58 million people with chronic hepatitis C. Prevalence is 0.74%, with 1.5 million new infection, with the 290,000 deaths. Hepatitis, the epidemiology in Indonesia. What's happened? Hepatitis B, based on our Recast test 2013, the proportion of HBH antigen positive was 7.1%, with the most cases in the 40 and 44 years age group. This is a very good age group. Hepatitis C, based on the survey results of the DGen P2P in 2007 until 2012, the prevalence of anti-HAV positive was 0.7%, with the most case being in the age of 20 of 29 years old. The young age is 30.9%, with a male to female ratio is 83 by 17. On the other years, based on Recast test 2013, the prevalence rose from 0.7% to 2.5%. It means there is evidence of C hepatitis that will be overgrowth in Indonesia. Hepatitis prevalence A, B, and C admitted in our General Hospital Muhammadiyah, which is Malang, showed 0.7%. There's 42 cases among total 35,822 patients admitted in our hospital during the 4 years. Materials and method. Methods measured in my samples consist in patients in UMM or admitted in UMM General Hospital. The period since January 2018 until December 2021. It is a 4 years period. Secondary data with diagnosed liver diseases is already done, and it is retrospective, observational, and analytical study. Result. This table shows the number of inspired patients during this period, 4 years period. This I divided into two period. This period, pre-COVID period, 2018-2019, and during the pandemic COVID, that is 2020 and 2021. Hospitalized patient, the pre-period, the pre-COVID period is showed 19,020 patients, but the liver diseases showed 116. And the second, the COVID area, but the pandemic period showed 16,802. And the liver diseases decreased to 90. Totally, we have 35,822 with liver diseases, 200 patients, 200 cases. It means to 0.5658%. The table of the gender. It looks like a relative difference between the pre-COVID and the COVID pandemic period. The pre-pandemic period, we showed that the male should 20 by 43 and 73, and the pre-COVID is 76 and 54. That is why it showed that in the male group showed that in COVID area is less than pre-COVID. It is 43, 69%, compared with 56, 60.31%. This is the table of comparison of patients in age groups. It showed that our patient mostly over 60 years old. In the ROF only placed 25.73, and secondly, this age of 50 under 59% showed 23.3%, and the third is 40 until 49 years old should 50.53%. Patient's variety. I found several diagnosis patients with chronic liver diseases during this 4 years period. First, placed by cirrhosis hepatis, hepatic cirrhotic. And secondly, by the reactive hepatitis, that named the non-specific reactive hepatitis. And 3 is fatty liver, NASH, non-alcoholic steatotic hepatitis. And the 4th is hepatitis B. And the 5th is acute viral hepatitis. It means this patient showed an hepatitis, acute hepatitis clinical symptom, but no marker of non-A, non-B, or non-C. 6, hepatitis A, and 7 is hepatitis C. Is the cirrhosis placed the first as first rank, it showed 33.5%. Preference between groups. We can see that the disease cirrhosis hepatitis showed 74 patients. It means 55.6% in the age over 40, compared with the reactive hepatitis, non-specific reactive hepatitis that showed in the young age, more than the old ages. It is showed at 26 patients. It is 35.62%. That is why the cirrhosis is placed by the older, but the reactive hepatitis is placed by the younger age. Discussion. I want to discuss about the pathogenesis of hepatic steatosis. The hepatic steatosis that is a hepatic fatty acid pool. It is a balance between fatty acid influx diet and the adipose tissue lipolysis plus the novo lipogenesis DNL and disposal fatty acids through beta oxidation or VLDL vs the secretion. If the pool is more than the secretion, the platelets, the steatotic droplets will be more, and the fatty liver will be followed. Secondly, the accumulation of lipid droplets. Lipid droplets depends on the intake and the reduce. The increase of intake fatty acids, it means that the droplets will be more deposited in the liver, and the reduced levels of fatty acids will be pulled in the liver area. There's some important other proteins involved in the different pathways, like ApoB, and there's the chromosome or the CD3, 36 that usually influence the autophagy mechanism. That is why if the CD6 increase, it expressed and more fatty will be pulled in the liver. And CD6 nowadays will be the marker of type 2 diabetes mellitus patient with obese diabetes. Purpose, the pathophysiology of liver injury upon SARS-CoV-2 infection. It is another mechanism compared with the virus A, B, or C. There is a COVID virus that already entered to our internalization to the liver cells, and then replicate in the cells, and the COVID will be associated with hepatocellular damage. The hepatocellular damage can cause the moderate steatosis, the lobular, the portal inflammation, the apoptotic or necrotic foci, and the elevation of plasma ALT and AST. Secondly, the preliminary observation. The injury might be caused by hepatocellular infection with direct cytopathic effect. This directly the virus will damage the liver cells of SARS-CoV-2. And secondly, induce the mitochondrial dysfunction or endoplasmic reticulum stress, both inducing the mitochondrial and ER stress contributing to steatosis. Furthermore, SARS-CoV-2 infection might also activate mTOR, inhibit the autophagy. This mTOR inhibit the autophagy, and this is the mechanism of viral degradation. If the autophagy inhibits, the viral replication will be increased, and it facilitates viral escape from the immune system, fade from the immune system. That is why the virus still survive. The third, the COVID-19 positive patients may be divided into 3 categories. In patients with liver diseases, we have a patient without pre-existing chronic liver diseases, patients with early stage chronic liver disease, and patients with advanced chronic liver disease or cirrhosis. And the last, the COVID-19 injury associated to liver injury with pre-existing liver disease, that non-alcoholic fatty liver disease, on an NAFLD, or associated with metabolic comorbidity, or induced hepatic decompensation. And there is no function of the liver, and it could prevent increase the mortality in cirrhotic patients. Treatment and management. The treatment goal is to stop the progression of the disease, the complications, and require a multidisciplinary approach. General management. The patients with chronic liver disease, mostly patients with one of this complication, mostly, but it can be also 2 or 3 complications present together. First is esophageal varices, the second is hepatic encephalopathy, the third is hepatorenal syndrome, the fourth is hepatocellular carcinoma. The hepatocellular carcinoma divided into initial states, intermediate states, and metastatic states.
やろうとしたんならさ、今度なんか、でもさ、
Specific treatment. The specific treatment of viral hepatitis, the alcoholic liver disease, non-alcoholic fatty liver disease, autoimmune hepatitis, hereditary hemochromatosis, Cooper overload, alpha-1 antitrypsin deficiency, drug and toxins, primary pericholangitis, primary sclerosing cholangitis, and Budd-Chiari syndrome usually showed the different strategy how to treat all these diseases that as a etiology of the liver disease. We see there is some patients must be transplanted. That's transplant can be performed in these patients. Recommendations for prevention care in chronic liver diseases. The first is avoid various types of alcohol, wine, liquor, and so on. Secondly, regular screening of hepatitis B or C hepatitis, and C, there's vaccination against hepatitis A and B. And 3, avoid iron. Usually, iron supplementation will be taken so widely. We are very careful, avoid the iron supplementation unless there is an iron deficiency. Avoid over-the-counter painkillers. Now we use acetaminophen, aspirin is so widely used, and usually we prevent the cardiac diseases, but we disrupt the liver diseases. Like this is another hepatotoxic drugs. And the last, maintain a good lipid profile. This to avoid metabolic syndrome and non-alcoholic fatty liver disease that will be the first of the liver disease that can progress to just fibrotic, cirrhotic, and at last will be the mortality will be increased. Conclusion. For my study in hospital, we found 206 liver disease patients. There are cirrhotic hepatitis at the first rank, 3.5. Secondly, is the non-specific reactive hepatitis, non-alcoholic steatotic hepatitis, hepatitis A, hepatitis B, hepatitis C, and acute viral hepatitis, and with the marker of non-A, non-B, and non-C. Secondly, serous hepatitis is the most cases in our hospital committed by age over 40 years, 55.64%. Followed by the others, the non-specific reactive hepatitis, non-alcoholic steatosis hepatitis, hepatitis B, acute viral hepatitis, A hepatitis, and C hepatitis. During the pandemic of COVID-19, serous hepatitis showed higher prevalence, 41 patients versus 28 patients before COVID. Our patients showed a very wide variety from the mild symptoms until the severe one. At last, prevention and early treatment are needed to prevent the acute disease develop to the chronic phase. And the chronic phase will be developed to the cirrhosis, and it is will be increasing the mortal rate of the patient itself. Acknowledgement, I want to say thank you to Mrs. Fini Ramawati as the translator. I want to have an effort to translate it, all the titles in Japan. Secondly, to my colleagues, Dr. Kerry Parmadi, internist, the position RSU is the head of outpatient installation. And secondly, to Dr. Rizky Amichayati, the position of as a medical service staff and head cost control quality control team. This is the end of my presentation. Thank you very much for the attention. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Prof. Joni, for the great presentation. I think it's on time. You can finish before 30 minutes. Thank you. And I would like to offer to the audience, if you want to ask to Prof. Joni directly, please, you can raise your hand, open the cam, open your mic, or you can write down in the chat box. The discussion session will last 10 minutes, and right after the speakers finish the presentation. Okay, while waiting, maybe I would like to ask to Prof. Joni and about your presentation. How about the severity and mortality between all of liver disease you have mentioned in your presentation in the hospital, especially?
Yeah, thank you very much. This is a common and a very interesting question. The first, I have mentioned that in our hospital there are some hepatitis B, hepatitis C, and A. I think the very danger to have to transmit to the other patients, that is B and C. But C, we know that the C transmit from the tools, usually for infection or sex intercourse, something like that. That is why we have to only take attention to the hepatitis A and B. But A, it can be solved completely. That is why there is no chronic type of A. And the last, we have to mention about the B hepatitis. The B hepatitis must be served as the standard procedure to make the other patients safe, and there is no transmission with the B patients. But in my opinion, during I've mentioned about our speakers. The next speakers is hepatitis and its treatment, and the other one is about the non-alcoholic fatty liver disease, and the last is the surgeon with the transplant, hepatic transplant. I find also I found also the fatty liver diseases. Fatty liver diseases, it is diagnosed by the ultrasonography. That is why I want to point highlighted the liver cytotic liver. That is why I want to discuss also the cytotic liver and to give the opportunity for our speaker, that is Dr. Nico, to have if want to have a study in our hospital. We have the patient yet.
Okay, thank you, Prof. Joni. So you invited the speakers to come to Malang to have some research in our hospital, right?
Because we have all cases.
How about the like examination, Prof? Do we have complete examination for the disease?
Yeah, we examine patients by the physical, but first taking the history. Secondly, the physical diagnostic, and third, the simple laboratory like SUT and CPT about the bilirubin, the German CT, the alkaline phosphate. And the third, if there is increasing of HUT CPT, we place the patient is in a liver disease or liver injury, and then we have to ask, we have to search about the markers, the A markers, B and C. After that, we have to follow with the USG. We compare with USG. How about the involving or the progressing of these liver diseases? And then we have to follow this patient for 3 or 5 days ahead to have the model of the SUT CPT. It is tend to be increasing or tend to plateau or will be decreased. Is there any comorbid diseases that can involve this liver function test? That is why I haven't found the liver diseases pattern in Indonesia as a country, but the A hepatitis or B hepatitis, there is, as already mentioned in my PowerPoint, there is a number of the hepatitis A and C in Indonesia. But the title is the clinical pattern of liver diseases. I haven't found it yet. That is why this is the first investigation or the first study for liver diseases in the hospital. It's very interesting. That is why. And actually, after at least I found so many fatty livers. That is why I give the opportunity for the such speakers for the statosis can we do more about these patients.
Okay, thank you, Prof. How about, okay, maybe I will check the audience if there's the attendees would like to ask to Prof. Joni. I would very delighted. Okay, the Putri Nurlaili, please open your cam, open your mic. You can ask to Prof. Joni directly. Hello.
Hello.
Okay, hello.
Okay. Dr. Ken Sato.
Yes.
Okay. Do you have any question to Prof. Joni?
Oh, so thank you very much for Japanese translation. I'm very impressed about your lecture.
You're welcome.
My question is, what time HCV genotype in prevalent in your country? Could you tell me?
No.
What kind of HCV genotype in prevalent in your country?
I haven't investigated the patient under the genotype. Just only the serologic type, is the hepatitis B, anti-HEV or HBAG.
Thank you very much.
Thank you, Dr. Ken Sato, for the question.
I think it is an opportunity for Professor Ken Sato to study in our hospital about the genetic type of this virus.
In Japan, actually, genotype 1B is prevalent in Japan. 1 and 2 is the main genotypes in Japan.
Okay.
the few patient has genotype 3. Other genotypes are not available in Japan. Okay?
Yeah.
Thank you very much
Yes.
Okay.
Thank you
for your
Professor
question.
Sato.
Thank you, Dr. Ken Sato. Okay, we still have several time. Maybe there's some questions again from the audience, or okay, may I ask you again, Prof. Joni? Maybe,
Please.
yeah. Okay, as we know that we have our health insurance, is that become obstacle to develop some diagnosis in your hospital, and or is it very like significant if we perform without health insurance or with health insurance, please?
Yeah, in my opinion, our health insurance, that name PPGS, it's very, very important and useful for our peoples. Most of our peoples. We have another insurances that the insurances can offer all the treatments for these patients, but about the PPGS, that's only for the primary treatment. For the other treatments, it must be constricted, and that is not available in the BPGS, except if the patients have in private insurance that is to be covered of all the medications.
Okay, thank you, Prof. Joni, for the answer.
Let me ask one more question.
Yes, please, Dr. Ken Sato.
We have recently experienced the liver injury, probably due to corona vaccine, COVID-19 vaccine. Have you experienced similar patient in Indonesia?
Yes. In our data, that the cirrhotic patients showed more in the area of pandemic. That is why the acute, we haven't found it. That is why so many people that vaccinated by the vaccine, I haven't found it. I know that one of the pathophysiology of the etiology of acute viral hepatitis recently is connected or inhibited with the corona vaccine. We haven't found it. All our COVID patients without any liver damage in the severe type, but they are in the mild type. Yes, there is an SUT, CPT increasing, but there is no encephalopathy, there is no jaundice, and there is no other complication of the severe acute viral infection diseases.
Okay, so you mean the disease is mild, right?
Yeah,
not severe form, I think.
Not severe.
Thank you very much.
All will be developed to the chronic type, and all will be turned to a cirrhotic type. And the cirrhosis will kill these patients, but not the acute type.
Okay, thank you very much.
You're welcome.
Thank you, Dr. Ken Sato and Prof. Joni, for the answer.
You're welcome.
Maybe from Prof. Yashiro, you have some question?
I'm sorry, I don't have it. So I think we had better go on to the next speaker.
Okay. Thank you. Okay, thank you, Prof. Joni, for great explanation and insightful discussion. Unfortunately, our time is up. Please have a rest, Prof, and we will go back to you in the last session for sharing discussion with other speakers. Okay, thank you, Prof. Joni.
Welcome.
Okay, we go to the next speaker. Our second speaker is Dr. Ken Sato, who will present about viral hepatitis and its treatment. Before I read his CV, I will greet Dr. Ken Sato first. Hello, Dr. Ken Sato, how are you?
Okay.
Okay,
so
thank you.
Let me share my slide. Is that okay?
Let me Okay, I will
you will?
read your CV first. Okay.
I've done, actually.
Okay. Okay, Dr. Ken Sato is an
Is there
associate
any
professor.
obstacle,
No.
conflicts? No.
No. This is great. Okay. Dr. Ken Sato, MD PhD, is an associate professor from Gunma University. He had 20 years experience since he graduated from Gunma University with his area of specialization in hepatology and gastroenterology, and a member to several professional societies. To all audience, if you have any questions, please write down your question in the chat box, or you can ask directly to the speakers during the discussion session that will be held after the presentation. Dr. Ken Sato, you have 30 minutes for presenting your topic. Please, time is yours.
Have you seen my slide?
Yes. But it's still not in the slideshow, Dr. Ken Sato. Maybe you can slideshow.
Is it okay?
Oh, but we can see the next slide. Or is it okay for you?
It's okay.
Okay. Yes, please.
Okay. Thank you very much for giving me the opportunity to show my lecture. The theme of my talk is viral hepatitis and its treatment. I'm belonging to the Department of Gastroenterology and Hepatology, Human University Graduate School of Medicine. This is my CV slide. My name is Ken Sato. My family consists of wife and 2 sons.
Dr. Ken Sato, I'm sorry.
Yes?
Can you stop? Yeah, because we can see the second slide of yours. We have
the second slide.
Yeah.
Oh, no.
So can you?
Which one?
Can you go back again to the
right now
before the slideshow?
Before the
slideshow. Before the slideshow, you can close the presentation first, maybe. I'm sorry, because your presentation haven't seen in full slide. Maybe you can close first your presentation.
加藤先生、日本語で、スライドがですね、見えてるんですけども、演者用で2つ出てるんですよ。
あ、そうですね。
はい。
じゃあ、
もし直せればという
これでどうでしょ
う ?OK。
Okay, yeah.
Perfect.
Okay, perfect.
Sorry.
Yeah.
About the interruption.
Okay.
So let's move on to the next slide. This is my CV slide. My name is Ken Sato. My family consists of wife and 2 sons. I'm an associate professor in Gunma University. Regarding age, I'm younger than Tom Cruise. Have you seen Top Gun Maverick? This is a famous movie.
Yes.
Actually, in Japan, the movie is now showing at the theater, but unfortunately, I wanted to go, but I haven't yet. My interest is movie watching, writing scientific article, and listening to English conversation program. Okay, so let's move on. This is my COI slide. So the first, according to WHO, about 55 million people suffered from chronic hepatitis C. About 290,000 people died. Do you see the 3 doctors got the Nobel Prize in Physiology or Medicine 2020? The prize motivation is for the discovery of the hepatitis C virus. If I have a time, I'll explain in detail later. So this is a clinical question. Why is the hepatitis virus important? Actually, this is a natural cause of liver disease. Ebola disease progression due to continuous infection of hepatitis B or C virus, which is the continuous infection. So the infection causes inflammation and fibrosis, and then progress to liver cirrhosis and hepatocellular carcinoma, like this, and hepatocellular carcinoma, like this. Acute viral hepatitis may cause liver failure, but also death. This one, jaundice, looks like yellow skin, ascites, and death. This is a big issue. So today is the time limited, so I focus on hepatitis virus. The virus consists of 5 viruses. Major 5 viruses are hepatitis A, B, C, D, E. Do you know the pictures? The guy's name is Shohei Ohtani. Have you seen him? Have you seen him? Do you know him?
No, we
He's
don't
a
know
major
him.
leaguer, slugger, and pitcher. He's a two-way player. He's a dream of Japan, I think. Actually, this is a picture of a bases loaded home run on May 9th, where I made this right. So at first, I introduced hepatovirus A. This is the order is picornaviruses, and the picture shows the billions by electron microscopic image. The structure is very interesting. The shape is regular dodecahedron, the diameter of 27 nanometer, and the virus is made of single-strand RNA. This is a nutshell of hepatitis A. Regarding epidemiology, there are estimated 1.4 million cases per year globally, and infections can be sporadic or epidemic. The transmission is via fecal and oral, such as person-to-person contact or consumption of contaminated food or water. The diagnosis is made by the presence of IgM, antibody to hepatitis A virus. But this disease is self-limited, so the treatment is supported. And regarding classical presentation, in children, most cases are symptomatic. But in the adults, some people develop jaundice, hyperbilirubinemia, right upper quadrant pain, and anorexia, and so on. Sometimes we experience unusual presentations like relapsing hepatitis, prolonged fibrosis, and acute liver failure. To prevent this disease, HIV vaccine is available all over the world. And for post-exposure prophylaxis, HIV vaccine and HIV immunoglobulin are available. And this slide shows the effect of HIV exposure in immunocompetent and immunosuppressed patients. Actually, there is no chronic hepatitis A. Acute form only exists. If the people experience HIV exposure, if the people who are immunized, they have already neutralizing antibodies, then HIV will be cleared. But the people who are not immunized, some people developed acute hepatitis, and if the people in immunocompetent, the virus will be cleared. But other people may develop persistent HIV viremia, but the viremia cannot be persist. So some cases develop acute liver failure, relapsing hepatitis, and prolonged phagocytosis. So what kind of diets are risky? Actually, infectious source or practice is MSM, males who have sex with males, and food, bivalve, such as raw oyster, fecally polluted vegetables, and fruitage. These are very dangerous regarding HIV infection. So next slide shows HDV, hepatitis delta virus. The shame of viral is shown like this. The single-strand RNA is surrounded by LHD antigen and small HT antigen. And these complexes are also surrounded by small HBS antigen, the blue ones, and M HBS antigens, green one, and L HBS antigens, red one. A very interesting structure. Regarding epidemiology, estimated 12 million cases exist globally, and geographic distribution is different from that in HIV. 0.61% of antibody prevalence rate in Japan are reported. Regarding transmission, blood or body fluid via cases are predominant. For example, drug abuser, person who receives frequent transfusion, and traveler from epidemic area. Diagnosis is made by IgM-HCV, HCV RNA, and HBV DNA. And treatment, regarding treatment, PEG interferon or interferon is available for this disease. Regarding classical presentation, varied from asymptomatic carrier to acute liver failure. And sometimes the disease progress to liver cirrhosis or hepatocellular carcinoma eventually. And the important points are infection can only occur under infection of hepatitis C virus. So this hepatitis C virus is incomplete virus. And the infection form is co-infection or super-infection on hepatitis B virus. The prevention measure is HPV vaccine. Regarding hepatitis E virus, this image is electron microscope image. The diameter is 30 nanometer. And this virus is also single-stranded RNA. Regarding epidemiology, there are estimated 3.3 million cases globally. And the disease is not only advancing countries, also Europe and Japan. 5.3% antibody prevalence rate in Japan is reported. Regarding transmission, fecal oral route, like hepatitis A, contamination of water suppliers or food is dangerous for this disease. Direct person-to-person transmission is uncommon, but transfusion is also the origin of hepatitis E virus. This is important in clinical setting. Diagnosis is made by IgM-HEV, IgHEV, and HEV RNA. Unfortunately, regarding treatment, no direct-acting therapy is available. Regarding clinical presentation, hepatitis E causes acute infection and mostly asymptomatic, but sometimes severe form or fulminant hepatitis are developed. Some cases progress to liver cirrhosis or liver failure. Important points are self-limiting basically and transmitted zoonotically through the consumption of undercooked meat. To prevent this disease, a prophylactic vaccine against HIV exists, but is currently only licensed in China. It's not available in Japan. Actually, these are rescue meals for hepatitis E. Raw or undercooked deer meat, boar meat, and pig liver. The young pig liver is risky. So let's move on to hepatitis B virus. This is the structure of HBV. HBV, the partial double-stranded circular DNA. And this is a picture, electron microscope image. HBV DNA was covered by HBC antigen. C means core, and circumstanced by HBC, HBS antigen. S means surface. HBV is a member of the hepatovirus family. Regarding epidemiology, there are estimated 350 million carrier cases globally. And there are estimated 2 billion people with past HBV infection. And there are about 1% HBV carrier cases in Japan. Regarding transmissions, blood and body fluid bear, such as drug abuser, person who receive frequent transfusion. But right now, the screening test has become better. So the origin of these cases is very extremely rare. And traveler from epidemic area, treatment by dentist, and acupuncture. The diagnosis is made by HBS antigen, IgM, HBC antibody, and so on. Treatment methods include nucleotide analog, PEG interferon, ursodeoxycholic acid, stronger neoimmunocomplex C, and so on. Clinical presentation varies acute infection to chronic infection. Some people progress to hepatocellular carcinoma or liver cirrhosis or liver failure. Important points are the clinical cause vary depends on the time of infection. This is important. Hepatitis B virus reactivation may develop in people with HB carrier on past HBV infection and immunosuppressive condition. Today, I underscore this sentence. This is most important for you, your student, your doctors, because HBV reactivation, you may experience HBV reactivation in your lifetime, maybe one time or more. If you go to the if you select any course, any clinical course. To prevent hepatitis B virus infection, vaccine against HBV is available. This is a chain of clinical cause of hepatitis B. Mother-infant transmission or the patient infected in early childhood, unfortunately, 9% patients become asymptomatic carrier. Then 10 to 15% progress to chronic hepatitis, and 85 to 90% of asymptomatic carrier become inactive carrier, fortunately. Then some of them can recover. And if the people infected in adults, more than 90% can recover. So this is important differences. Some of them become HCC, developed hepatocellular carcinoma from inactive carrier. And some of them, unfortunately, progress to chronic hepatitis and liver cirrhosis. Then some of them can progress to HCC. And last, hepatitis C. This is a schematic diagram. A small enveloped single-strand positive sense RNA virus. Regarding epidemiology, there are estimated 71 million cases globally, and 0.9 million cases are reported in Japan. Regarding transmission, they're similar as hepatitis B, but infection power is weaker than hepatitis B. The diagnosis is made by hepatitis C virus antibody and serum HCV RNA itself. Treatment method comprises of interferon-free direct-acting antivirals, UDCA, stronger neoimmunocomplex C. Some people progress to chronic hepatitis C, just the ratio is 20 to 30%. So fortunately, unfortunately, 70% of patients fortunately are cured. I'm sorry, 70% of patients progress to chronic infection. 20 to 30% of patients are cured. This is problem. Some patients progress to HCC, liver cirrhosis, or liver failure. Important points are HCC may develop even after viral eradication by direct DAS, and DAS are not available for decompensated liver cirrhosis with severe renal dysfunction. For prevention, unfortunately, no vaccine is available, but the vaccine is still under development. They cannot give up. This is the shame of DAA, direct acting antivirals. This is the structure of Hepatitis C virus. And this non-structural proteins are targets, these three parts. Then usually we use combination of DAs, not just one DAA, because chronic hepatitis, because hepatitis C virus is very smart, so developed easily drug-resistant virus. So these are the summary of DAS in Japan. So the Grecapivar and Pibrentasvir is famous and more prevalent in Japan, I think, because the treatment periods are very short, 8 weeks in chronic hepatitis C. But in general, 12 weeks treatment periods are common. Some of them, so this one, Sofosbuvir and Velpatasvir therapy is only available for decompensated cirrhosis for children, adolescents. Grecapivar and Pibrentasvir therapy are become available recently. So this is the last slide, today's takeaway. To understand viral hepatitis, self-limited or transition to chronic infection. This is important. Post-stage primates or zoonosis, vaccine is available or not, viral elimination is possible or not, which virus is needed for infection of another one, which is DNA virus. In the prognosis affected by the time of infection. So thank you very much for your attention.
Thank you, Dr. Ken Sato, for the interesting presentation. Okay, we go to the discussion session. Please, the audience, if you would like to ask to Dr. Ken Sato directly, maybe you can raise your hand, open your mic, open your camera, or you can write down in the chat box, and Dr. Ken Sato will answer it. Maybe I will offer to the audience. Is there any question? Okay, Prof. Joni, do you have any question for Dr. Ken Sato?
Thank you. Thank you very much, moderator. Thank you, Dr. Ken Sato, for your nice presentation.
Thank you very much.
It is very educable. I want to ask just, I have some patients with HB antigen positive, and the CBT are nearly normal. Usually we cannot give some antiviral in these patients because the virus is not activated. Is it true? If the viral is activated, then the viral will be ingest the drugs, and the virus will be finished. But in patients with the CBT normal, Usually, we think that the virus is not active and the virus, but still in the body, in the bloodstream, and also in the liver. And once upon a time, there will be flare and will be activated, and will be the patient turned to as a patient, hepatitis patient, and it can be acute or it becomes chronic. And what is your strategy for this patient with HA antigen positive, but the HUD-GBT nearly normal? Thank you.
Thank you very much for your question. I think in Japan, inactive hepatitis B carrier is not a candidate for treatment because some patients can eliminate the virus themselves. That's why. Usually, we treat the patient with hepatitis B virus in case of high ALT level and also high HBV DNA viral level. These components are very important for decision of treatment for hepatitis virus. Is this answer meet your question?
Yes, we know that if the patient, if the virus is active, no one we can do, just only to increase or to restore the immune of the patients. Then the patient can activate their macrophage, and macrophage can phagocytate all the viruses, and the patient will be self-remitted. Usually, that is the mechanism. But while the mechanism involved, but during that time, the carrier will be transmitted to other persons. That is why in this patient, the household, all the household will be vaccinated to prevent the transmission of the disease. But for others, because so many workers, if they're HB positive, or SUD-CBT is normal, they are refused for as an employee in that maybe in a company, something like that. What is your opinion? So many patients that refuse to work in a company because the HB antigen is positive, while the SUD-CBT is normal. As I give a mention that the patient is normal patient, but he suffers or he carried some antigen that directly possible for another man transmission. What is your opinion?
Thank you very much for your question. I understand your question. I think at first, the infection risk of hepatitis virus is not so high, I think. The dangerous material is blood, sweat, or blood fluid, body fluid can be infectious, but this fluid can contact with wound, not normal skin, okay, or mucosa. Otherwise, hepatitis B virus infection cannot be occur. So the company is overdoing. My recommendation is if the company is fearing the risk of hepatitis B virus, the person works in the company should take the vaccine. This is I think this is a good precaution for prevention of hepatitis virus infection, I think. Is it okay?
Yeah, thank you very much.
Thank you very much.
Thank you, Prof. Johnny and Dr. Ken Sato for the answer. Okay, we have one question in the chat box. It's from Dr. Winda. Is she allowed to ask the question a little bit out of the topic, Sensei? Is that okay? She asks you permission.
Sure. Go ahead, please.
Okay, go ahead, please. Maybe you can ask to Dr. Ken Sato. You want? Okay, directly, please. Dr. Winda, please unmute.
Okay, thank you very much, Dr. Aryani. Konnichiwa, Ken Sato Sensei. Watashi wa Winda desu. What a interesting topic you have informed us before.
Thank you very much.
I'm so sorry if a question is out of the topic, but this is my big question lately, Sensei. Nowadays in Indonesia, there is a pediatric hepatitis outbreak, which is attacked by non-hepatitis virus, like an adenovirus. In the past, we have known that adenovirus mostly attack our respiration system, right? And I would like to know if there is any mutation of adenovirus themselves to attack humans hepatocyte, or maybe is some unique characteristic of some patient who are more susceptible to get hepatitis at causa adenovirus. Arigatou gozaimasu, Sensei. Thank you, Dr. Aryani.
Thank you very much for your question. In your question, the adenovirus can hepatitis, you mean? Okay.
Yes, right, Sensei.
I think it's possible, but it's not common. So I think the WHO is very anxious about this, I think. Right now, because we actually experienced one case of unknown hepatitis, then we submitted the blood and stool for inspection of adenovirus presence, but unfortunately, they cannot detect the presence of adenovirus. But according to the report, several cases might be detected in Japan. So right now, I'm not sure. Actually, I cannot answer your question enough. But still, we have to take care about this special event or hepatitis, I think. Thank you very much.
Okay, thank you, Dr. Ken Sato. I think we need further research since the disease still have us in lately. Okay, maybe I will offer once again to the audience. Do you have any question, dear attendees? If we have no question, should we go to the next speaker, Prof. Yashiro? Okay, thank you. Okay, thank you very much, Dr. Ken Sato, for the presentation. You're welcome. And interactive discussion. You can have rest a little bit, Doc, and we go back to you in the last session for sharing discussion with other speakers. Okay, our third speaker will be Dr. Makito Bari, the most beautiful speaker here, who will present about diagnosis and treatment of non-alcoholic fatty liver disease, NAFLD, or non-alcoholic steatohepatitis, or NASH. Before I read her curriculum vitae, I will greet Dr. Makito Bari. Hello, Dr. Makito Bari. Hello, how are you?
Yeah.
Yes, clear and loud, Doctor. Okay, it's great to have you here. Allow me to read your curriculum vitae briefly. Makito Bari, MD PhD. She's from Department of Diagnostic Imaging and Interventional Oncology, Juntendo University, Tokyo, Japan. She took her medical program in Teikyo University, Tokyo, Japan, and finished her residency program in Department of Internal Medicine and Gastroenterology, Tokyo Women's Medical University, Tokyo, Japan. In 2021, she became an associate professor of Department of Diagnostic Imaging and Interventional Oncology, Chimtendo University, Tokyo, Japan. She's also a part of several professional societies in the field of gastroenterohepatology and endoscopic, if I'm not mistaken. To all audience, if you have any questions, please write down your question in the chat box, or you can ask to Dr. Makitobari directly right after she finished the presentation. Okay, Dr. Makitobari, your time is 30 minutes. Please, time is yours.
Hello, good afternoon, everyone. First, I would like to thank Dr. Tutuli for introducing me so kindly, and I'm greatly honored to be able to speak here. I'm sorry, but I'm not good at English, so I made a video yesterday. So please enjoy my lecture and video.
Thank you.
I share my video.
Yes, please.
Can you see?
Yes, this is your slide, right, Dr. Makitobari?
Okay.
Yeah.
Yeah. This is buildings of Chimtendo University and hostel. There is in Tokyo, Japan. They are members of the Department of Gastroenterology. Today's topic is diagnosis and treatment of NAFLD NASH. My talk will be in 3 parts. What are NAFLD and NASH? How to diagnose NAFLD and NASH? How to treat NAFLD and NASH? So let's start with what are NAFLD and NASH? Sorry.
Yes.
Professor Lobby, he first proposed the concept of NASH in 1980, and his disciple is my mentor, Professor Etsuko Hashimoto. Non-alcoholic fatty liver disease, NAFLD, is a hepatic manifestation of metabolic syndrome and currently the most common chronic liver disease. Excessive eating and lack of exercise induce a visceral fat accumulation, and it produces metabolic syndromes such as dyslipidemia, hypertension, and diabetes. NAFLD develops based on these. Non-alcoholic fatty liver disease, NAFLD, consists of 2 clinical entities. Most patients are non-alcoholic fatty liver, NAFLD, that generally follows a non-progressive course, while a part of NAFLD patients have non-alcoholic steatohepatitis, NASH, which can progress to cirrhosis. Lifestyle changes have resulted in a dramatic increase of obesity and a metabolic syndrome worldwide, with obesity becoming a major public health problem. Prevalence of obesity is on the rise in Asia. Also in Indonesia, the proportion of obese people is increasing rapidly. That said, the prevalence of obese people in Japan and Indonesia is lower than in Europe and USA. However, the prevalence of NAFLD is not so different in Asia and USA. Asians have a higher prevalence of NAFLD and diabetes than degree of obesity, and are vulnerable to obesity. The difference in these prevalences and the prevalence of NAFLD. The most famous risk gene is PNPLA3, which is said to have a 15 to 25 prevalence in Caucasians, while a 30 to 45 prevalence in Asians. Diagnosis of NAFLD/NASH varies slightly from country to country. There are racial differences in the prevalence of NAFLD, and we Asians are more likely to develop NAFLD even with a lower BMI than Westerners. For this reason, I will talk about diagnosis and treatment of NAFLD-NASH, mainly in Japan today. Etiology of NAFLD-NASH. Prevalence of NAFLD is about 30% in Japan, and NASH is 10 to 20% of NAFLD cases, making the estimated prevalence of NASH is 3 to 6%. There are gender differences in the prevalence of NAFLD. Males range from middle-aged to elderly at approximately 30 to 40%, while females have a lower prevalence until middle-aged and increase sharply after menopause. About lifestyle-related disease complication rate in NAFLD patients. Means when BMI exceeds 25, 60% of men and 30% of women have NAFLD. When BMI exceeds 30, more than 80% of both men and women have NAFLD. Green bar is NAFLD, orange bar is NASH. The prevalence of diabetes is about 30%, and impaired glucose tolerance is as high as 70% in NAFLD and NASH patients. In NASH, 60% of patients complicate dyslipidemia and hypertension. Genesis of NAFLD. In NAFLD and NASH, insulin resistance, inflammatory cytokines, oxidative stress, genetic factors, etc., are hit in parallel to form a disease condition. I'll show you the progression of NAFLD-NASH in pathological. This is an animation of situation seen under a microscope. Fat deposit in hepatocyte resulting in fatty liver. Hepatitis occurs when inflammatory cells infiltrate around the central vein and cause hepatitis. When the inflammation continues, fibrosis develops. Another progression of liver fibrosis eventually leads to cirrhosis. Prognosis of NAFLD. Recently, NAFL and NASH are known to migrate to each other. If we follow up with 100 NAFLD patients, about 5 will have cirrhosis in 20 years, and 0.5 patients develop hepatocellular carcinoma (HCC). At first glance, it looks less, but NAFLD has the prevalence of 30% of population, so it can be seen that the number of cirrhosis and HCC patients is extremely large when considering society. It is known that patients with NAFLD have a higher mortality rate than healthy controls. The leading cause of death in NAFLD patients are malignant tumors, and the second is ischemic heart disease. However, when we limit to liver cirrhosis, the leading cause of death is liver failure, and the second is HCC. In short, if you look at NAFLD as a whole, the elements of lifestyle-related diseases come to the front. The cause of death are malignant tumors and cardiovascular diseases, but liver-related deaths increase in patients with liver cirrhosis, as in other causes of liver cirrhosis. In recent years, the background liver disease of hepatocellular carcinoma has changed. Recently, the number of non-B, non-C has been increasing. Non-B, non-C include various diseases other than NAFLD. It is important to note this unclassified group includes Barnard of NASH disappear, making it difficult to diagnose NASH. It is known that incidence rate of HCC in NAFLD are 0.51% per 12 years. However, for NASH cirrhosis, the incidence rate of HCC is 11.3% in 5 years. It has the nearly same incidence as alcoholic cirrhosis. Now, I present a case of liver cancer in a NAFLD patient. I don't have time, so I will present it briefly. The case is a 52-year-old man. He was pointed out a liver tumor in the first medical examination. His BMI was 38, and he had hypertension and dyslipidemia. Abdominal enhanced MRI showing HCC in the left medial segment of the liver. He received curative extended left hepatectomy. His non-cancerous lesion showed steatohepatitis. Summary of what are NAFLD and NASH. 30% of the general population is NAFLD in Japan. There are racial and gender differences in NAFLD. NAFLD patients have a high rate of lifestyle-related diseases. In NAFLD, the cause of death are often vascular events and malignancy. However, when limited to NASH cirrhosis, there are mainly liver-related diseases such as HCC and liver failure. Hepatocellular carcinoma with background of NAFLD is on the increase. Incidence rate of HCC in NASH cirrhosis is 11.3%, 5 years. The topic is how to diagnose NAFLD and NASH. Definition and diagnosis of NAFLD is as follows. At first, evidence of hepatic steatosis. Next, lack of secondary causes of hepatic fat accumulation. And it is necessary for diagnosis of NASH that the presence of steatohepatitis in histologically. Let's take a closer look at each item. First, evidence of hepatic steatosis. The diagnosis of hepatic steatosis can be using either imaging or histology. Hepatic fat is stored in the cytoplasm of hepatocytes as fat droplets. In histology, fatty liver is diagnosed when there are 5% or more fat deposition. Diagnosis of fatty liver using imaging modality. When fat is deposited in the liver, ultrasound makes the liver whitish and increased contrast with the kidneys. On the other hand, in CT, the density of the liver decreases and it becomes darker. The liver to spleen attenuation ratio is less than 0.9. In recent years, modalities which can quantitatively measure the degree of fat deposition have become widespread. There are modalities using ultrasounds and using MRI. Next, about lack of secondary cause of hepatic fat accumulation. We should exclude the secondary causes of hepatic fat accumulation. What were the secondary causes of hepatic fat accumulation? Of course, significant alcohol consumption, genotype 3 hepatitis B virus, long-time use of steatogenic medication, for example, corticosteroids, tamoxifen, amiodarone, etc. Of course, we need to exclude significant alcohol consumption, but NAFLD is allowed to drink not to cause liver damage. The upper limit of alcohol drinking is with ethanol, 30 grams or less per day for men, 20 grams or less per day for women. And it is necessary for diagnosis of NASH that the presence of steatohepatitis in laparoscopic. We use such methods to perform liver biopsy, and usually using ultrasounds. This is me. Diagnosis of NASH or with inflammatory cell infiltration and ballooning of hepatocytes, in addition to more than 5% or more fat deposition. This is a slide with HE staining. These findings are mainly seen around the central vein. You can see inflammatory cell infiltration around the central vein. We can clearly see steatosis and inflammation around the central vein. You can see normal-sized hepatocytes in the upper right corner, while ballooning of hepatocytes indicating necrotic change can be seen on the left side. And in NASH, Mallory dead body is also often seen. Additionally, laparoscopic liver biopsy is done. NASH is diagnosed from liver biopsy on the basis of the presence of stem hepatitis. So liver biopsy is essential to diagnose NASH. However, liver biopsy has several drawbacks. It is an expensive and invasive procedure, and there is potential to sampling error and variability in interpretation by pathologists. And NAFLD and NASH have been found to transition to each other. In other words, NAFLD and NASH are likely to see different phases of the same disease. So, in clinical, NAFLD and NASH are collectively treated as NAFLD. However, it is difficult for hepatologists to treat all of the many NAFLD patients, who are 30% of the population. The factor that determines the prognosis of NAFLD is the severity of fibrosis. Survival curve of patients with mild fibrosis are similar to that of controls, but the prognosis of worsening in severe fibrosis patients. Hepatologists need to focus on patients with NAFLD who have fibrosis. Now, how do you diagnose fibrosis? About diagnostic methods for fibrosis. Invasive methods. Invasive methods are liver biopsy and laparoscopy. This is liver cirrhosis. Next, from invasive methods. Diagnostic markers for liver fibrosis are platelet count, hyaluronic acid, typhocollagen 7F, M2B59, and autopsy. In Japan, these are covered by insurance. The cheapest and easiest way to measure is platelets. Generally, the index of liver cirrhosis is 100,000 or less. In NAFLD, we suspect cirrhosis when platelets fall below 150,000. Scoring system for liver fibrosis in NAFLD. Various scoring systems have been proposed in NAFLD, but Simple Index and NAFLD fibrosis score are superior in terms of usefulness and convenience. There are sites on the internet where these scoring can be easily calculated. Elastography is an item that can objectively evaluate the stiffness of the liver. This is elastography, which uses the technology of ultrasounds. These are also elastography using ultrasounds. And this elastography is using MRI. Here, fibrotic areas are shown in red. It is necessary to have a system in which general physicians and doctors in charge of medical checkups and hepatologists cooperate to treat patients with NAFLD. In Japan, NAFLD NASH practice guidelines recommend practice according to this flowchart. However, it takes time to read, so I will briefly show it next. All NAFLD patients should receive screening for liver fibrosis and pick up patients with fibrosis, that is, those in need of intensive care. I will explain it by comparing it to a traffic signal. At first, general physician or doctor of medical checkup evaluate the risk of fibrosis by scoring Husserl FIB-4 index or NAFLD fibrosis score. FIB-4 index is often used in daily clinical practice because it can be evaluated only by age, AST, ALT, and platelets. Low-risk patients in green will be followed by the general physician and doctors of medical checkup. Patients with middle or high risk, yellow or red, should be referred to a hepatologist. Hepatologists will perform elastography or liver biopsy to assess the degree of fibrosis, and surveillance and therapy should be considered depending on fibrosis stage. Summary of how to diagnose NAFLD and NASH. Definition and diagnosis of NAFLD-NASH is evidence of hepatic steatosis, lack of secondary causes of hepatic pathophysiology. When there are steatohepatitis in histologically, we diagnose NASH. The factor that determines the prognosis of NAFLD is the severity of fibrosis. Fibrosis is assessed by fibrosis score, imaging, and histology. Surveillance and therapy should be considered depending on the fibrosis stage. Finally, I will talk about the treatment of NAFLD-NASH. The basis of treatment for NAFLD is lifestyle improvement. In Japan, NAFLD-NASH practice guidelines recommend to treat according to this flowchart. For NAFLD, we propose lifestyle improvements and treat any lifestyle-related diseases that are complicated. At NASH, treatment is performed according to the following flow. When hepatic fibrosis is suspected in NAFLD, it should be treated as NASH. In obese NASH, body weight reduction is recommended. 3% or greater weight reduction improved hepatic steatosis, and 7% or greater correlated with improvement in the NASH. So the target for weight reduction is -7% by diet and exercise therapy. Diet therapy for NAFLD. At first, calculate the standard weight and decide daily energy intake according to the activity intensity. Exercise content is a combination of aerobic exercise and resistance exercise. Now, I present a case in which liver enzymes have been normalized by weight reduction. Patient is 21-year-old man. He started to gain weight from junior high school students. He visited our hostel because he was pointed out a liver disorder. He was 162 centimeters tall and weighed 91.3 kilograms. BMI was 34.5, and he had hypertension and dyslipidemia, and his transaminase was very high. He had fatty liver in brutal cells. I ordered weight loss with diet and exercise, and he finally succeeded in losing more than 10% of weight. normalize the transaminase and improving blood pressure. We consider bariatric surgery if BMI is 35 or higher. In Japan, only sleep gastrectomy is covered by insurance. From now on, I will talk about pharmacological treatment. We consider medication therapy for non-obese NASH or NASH that fails to lose weight. At present, there is no established pharmacological treatment for NAFLD. Provide pharmacological treatments for complications such as diabetes, dyslipidemia, and hypertension. Type 2 diabetes. Pioglitazone, SGLT2, and GLP-1 receptor agonists are given to patients with type 2 diabetes. Dyslipidemia. Statin and selective PPAR alpha modulator are given to patients with dyslipidemia. Hypertension. ARB or ACEI are given to patients with hypertension. Last is vitamin E. Vitamin E is often given to NAFLD patients who do not have lifestyle-related diseases, and vitamin E is also added in addition to therapy for lifestyle-related diseases. In end-stage cirrhosis, weight reduction rather makes it worse in condition. Liver transplantation is also indicated for end-stage cirrhosis. Approximately 30% of cases of recurrence of NAFLD after transplantation. However, stem hepatitis is mild and the survival rate after transplantation is good. Now, I present a case of liver failure caused by NASH in an obese young male. He was a 32-year-old man. He had been obese from 6-year-old. At the age of 30, elevation of transaminase was found. At the age of 32, he developed severe fatigue and he came to our hospital. He was 165 centimeters tall and weighed 135 kilograms. BMI was 49.5. Low platelet counts on albumin and high bilirubin and MHC. It seems like liver cirrhosis. We performed liver biopsy. Marrow stain showing broad fibrosis with moderate mixed inflammatory inferior grade and regenerated nodules. The high power field shows moderate steatosis, ballooning, and marrow bodies. Based on these results, we diagnosed NASH with advanced cirrhosis. After he was discharged, we followed up in the outpatient department, but dietary guidance was ineffective. He was too obese to exercise, and his weight continued to increase. After that, he stopped coming to our hospital. Eventually, he developed encephalopathy, ascites, and jaundice, and he was taken to the hospital by ambulance. Almost 2 years after the diagnosis, at the age of 34 years, he died as a result of liver failure. He was received autopsy. The liver was found to be macronodular type cirrhosis. It was atrophied and small. If he had been diagnosed with NASH before he had severe cirrhosis, he might have been treated with bariatric surgery, and if he had been properly outpatient, he might have been able to have a liver transplantation at the point suggested case. Summary of treatment for NAFLD NASH. The principle of treatment of NAFLD NASH is weight reduction by exercise and dietary restriction. Aim for weight reduction is -7%. We should consider bariatric surgery for severe obesity. For NAFLD NASH patients with diabetes, dyslipidemia, and hypertension, provide pharmacological treatments for each complication. Liver transplantation is indicated for NASH with liver failure. Take-home message. Diagnosis of NAFLD. 1. Evidence of hepatic steatosis. 2. Lack of secondary causes of hepatic fat accumulation. And when there are steatohepatitis histologically, we diagnose NASH. About 30% of general population have NAFLD. The factor that determines the prognosis of NAFLD is severity of fibrosis. It is important to pick up cases of advanced fibrosis and observe them intensively. Currently, there is no treatment for NAFLD NASH that is superior to weight loss. Pharmacological treatments are given for each comorbid lifestyle-related disease. Thank you for your attention.
Thank you, Dr. Makitobari, for for your great presentation. It is interesting to hear your presentations because there are several specialty examinations haven't routinely performed in Indonesia because the limitation of finance and facility, of course. And it is important for the general practitioner for understanding the basic examination for NAFLD or NASH. And it's also need a comprehensive treatment between medication and lifestyle change, right? Okay, I would like to offer to the audience if there are some questions. Or Prof. Joni, do you want us some question to Dr. Makitobari?
Thank you, moderator. Thank you for Makitobari for your nice presentation. I just want to know that you have mentioned that NASH will be progress to liver fibrosis, and at the end of liver fibrosis is liver cirrhosis. And the liver cirrhosis, we know the liver cirrhosis have a macro or micronodular, and the macronodular usually progress to the cancer, liver cancer, and the other one to the liver failure. Can you give me some marking which NASH that could progress to liver cirrhosis, on the other hand, will be persist as a NASH?
Old men and not controlled DM patients are often progress to the cirrhosis, right? Can you hear me?
Can you repeat again, Dr. Makitobari?
Can you hear me?
Prof. Joni? Oh, okay. Yeah. Okay. You can wait a second. Prof. Joni, can you hear?
We can hear your voice, I think.
I think there is a problem.
Next question.
Oh, okay.
Next.
Okay. I think Prof. Joni, it's okay, Prof. Okay. I think Prof. Joni still have a trouble in the audio, but we can clearly hear your voice, Dr. Makitobari. Maybe you can repeat your answer again to Prof. Joni, please.
Can you hear me?
Yes. Oh.
Old men and not controlled DM patient probabilities for the cirrhosis often. Is it?
Oh, how old is the age? 40, 50, or 60 years old? Because nowadays we find patients with liver cancer younger in the age compared with the former.
Mostly, and liver cancer occur at the elderly patient, but rarely. Some patients occur the young male. I report the 3 male under the 15-year-old men last one I report, and their obesity in a child and not they are not know the obesity is not so good, and BMI over the 35 is risk, I think, in the child, from the child. I'm sorry, I'm not good at English, sorry.
No, my last question, please. You know that in your country, there is a sport that's called sumo. The sport, the boys will be feeding so big as possible. And now about your health minister or health centers, medical centers, about the sumo activity, because they are feeding to be bigger and bigger and bigger. The bigger is the better, and the bigger will be the winner. Is that right?
I'm sorry, I can't follow you.
Do you have some data among the sumo sports persons? Are they all got or progressed to liver statotic?
I don't know when he was their child, and I'm sorry.
Yeah, because they are obese, but they did so have many effort and so heavy sports. That is why there is a caloric for catabolics, and there is food feeding for anabolics. Maybe there is some equilibrium between feeding and storing these fat materials in the liver.
小林先生、相撲レスラーとかそういった人で参考になったようなデータは先生ご存知でしょうかみたいな内容かなと思うんで。
Small wrestlers have a very many muscle, I think. Sarcopenia is worse for not good for NASH. Small wrestler has many muscle, so I don't know the small wrestler's NASH.
Okay, thank you.
Sorry.
Okay, Dr. Makito Bari, thank you for your answer. I think it's interesting question from Prof. Joni, since Japan is the country of sumo sport, right? And then I think since we have no further question in this session, Should we go to our last speaker, Prof. Yashiro?
Yes, please.
Okay, thank you very much. Okay, Dr. Makitobari, thank you for your great presentation and the discussion. And we go to the last session, but please don't go anywhere. In the last session, there will be sharing discussion with other speakers. Okay, our fourth speaker is Dr. Yoichi Kawano, who will present about liver surgery or liver transplantation in Japan. This topic is like cake with cherry on top, because after we knew about the disease and medical treatment, we'd like to hear some experience in liver surgery and transplantation, especially in Japan. Before I read his curriculum vitae, I will greet Dr. Yoichi Kawano. Hello, Prof.
Hello,
Yoichi
can you hear
Kawano.
me?
Hello.
Hello, can you hear me?
Yes, clear and loud, Prof.
Okay.
I would like to introduce you, Dr. Yoichi Kawano from Department of Surgery, Nippon Medical School, Chiba Hokuso Hospital, with specialized field in general gastrointestinal surgery, hepatobiliary pancreatic surgery, and transplant surgery for liver. He is a certified skilled doctor for liver and counselors of Japan Society for Endoscopic Surgery. He became associate professor in this year, in 2022. To all audience, if you have any questions, please write down your question in the chat box, or you can ask to Dr. Yoichi Kawano directly, and he will answer in this discussion session. Dr. Yoichi Kawano, I'm sure you have lots to share here, and I hope 30 minutes is great time for you, please.
Okay, thank you very much. Selamat siang kenalkan, nama saya Yoichi Kawano. Hello everyone, it's a great honor for me to be here today. I sincerely appreciate Dr. Aryani and all facilities. So I'd like to talk about liver surgery and liver transplantation in Japan. I have no COI. I'd like to introduce myself briefly. I was born on September 1st, 1971. I used to play rugby football from junior high school to college. I graduated from Nippon Medical School in 1997. Today's topics are: the first one is past and current of open and lap liver resection in Japan. Second one is past and current of liver transplantation in Japan. First of all, I'd like to show you a brief history of liver resection. 1654, Grissom described the liver triple vascular system. After that, Rex and Country revealed the ciliary, right and left lobes are divided by the line connecting the gallbladder bed to the IVC. In 1908, Pringle invented Pringle's method to control bleeding from the liver. In 1950, Professor Honjo performed the first successful right lobectomy in the world. And in 1954, Quino proposed concept of the 8 segments. However, about 20 years from 1950s, the result of liver resection can be said truly a disaster. For your information, in 1881, Bill Laws performed distal gastrectomy. In 1970s, after the clamp clutching method using carries was invented, the results have been improving. In 1980s, Professor Makuuchi invented many innovations in liver surgery, such as systematic subsegmental hepatectomy, Makuuchi criteria using indocyanin green, so-called ICZ, portal vein embolization, and intraoperative ultrasonography, and many others. His achievements have dramatically improved that result. He is quite simply to say the father of liver surgery. He is the pride of Japanese liver surgeons. I used to work with him for a short time. In 1991, Reis performed the first laparoscopic hepatectomy. After that, 3D simulation and navigation technology, ICG, fluorescence imaging, robotic liver resection, and associating liver partition and portal vein ligation, so-called ALPS operation were invented and developed. I will show you a surgery-related mortality after liver cancer resection in Japan. Exceeded 15% in the 1970s, but decreased rapidly in the 1980s and reached a level as low as approximately 1% in the 1990s. While several factors may have led to the rapid decrease in mortality in the 1980s, the establishment of safety limits for the extent of liver resection in injury livers played a major role. In Japan, when determining resectability, the severity of liver impairment is accurately assessed on the basis of the indocyanine green ICG tolerance test. The so-called Makuuchi criteria for hepatic resection is widely used in Japan and other Asian countries. Professor Makuuchi also developed a method consisting of artificial embolization of the right branch of the portal vein in order to cause atrophy of the resected side and enlargement of the remaining liver. Introduction of this method has markedly improved the safety of the extended lobectomy in the treatment of hierocholangiocarcinoma and has since been applied to the surgical treatment of much liver metastasis and HCCs. Next, I'd like to talk about laparoscopic liver resection. As you know, LLR has many advantages compared with open liver resection. Complications, blood loss, transfusion rate, and hospital stay are better in LLR. Our country has surgical skill qualification system of endoscopic surgery. This system was developed by the Japanese Society for Endoscopic Surgery and has been used since 2004. Various minimally invasive surgical procedures from digestive to gynecologic, urologic, or orthopedic procedures can be evaluated by submitting unedited full-length videos of procedures. The acceptance ratio is around 25% in the liver field. It is no exaggeration to say that this system guarantees safety spread of the procedure in Japan. When I'd like to introduce about safe dissemination of LLR in Japan, I will show you a brief history of LLR in Japan. In 1993, Professor Kaneko performed the first LLR in Japan. In 2010, the national insurance approved to cover minor LLR. So this procedure has been introduced into daily clinical practice. In 2016, Japanese national insurance approved major LLR. This event provided a strong positive impact on LLR. You can see the result of the surveillance by the National Clinical Database. Operative mortality rate was highest in major liver resection, 3.7%. However, the mortality rate of LAP procedure was 2.3%, and the odds ratio was 0.83. The better safety of LLR than that of open procedure was proven then. The slide shows annual number of open liver resection in blue column and lap liver resection in red column. The ratio of lap liver resection was 10% in 2011, but has recently increased to 25% and still increasing gradually. And the number of hospitals can perform LLR are more than 600 in Japan. The recent mortality rate of LLR is shown here, even in the major resection shown in lower column. The mortality rate is less than 1%. This result indicated our LLR are safely performed all over Japan. I will show you my video to conduct a lap left hemihepatectomy consists of 4 steps as follows. We start the operation on this setting. At the first, we prepare the peeling group maneuver. The Grison capsule at the right and the left side of the base of the umbilical portion are gently revealed. After the encircle of the left Grison pedicle, the pedicle is temporarily tied to interrupt the blood inflow and to reveal the demarcation line on the liver surface. The left Grison pedicle is cut using suturing device. After that, the root of the left hepatic vein and the left superficial vein can be detected. The root of the LHV is clipped and divided. The MHV is exposed from the cornea to the caudal side to prevent tearing injury of branches of the MHV, and the dorsal liver parenchyma of the MHV is transected. After that, the remaining liver parenchyma between the MHV and the demarcation line is transected from caudal to cranial side. You can see the hepatic vein for the segment 4. You can see the another hepatic vein for the segment 4. You can see the transected plane with revealing full length of the MHV. I will show you a short video of robot left hemihepatectomy with hepatoduodenal lymphadenectomy provided by Professor Go Wakabayashi, who is the authority of laparoscopic and robot liver resection all over the world. Robot can perform hepatoduodenal lymphadenectomy very well. Most of laparoscopic procedure will be body axis direction, and procedures of horizontal direction must be difficult. But robot is good at the horizontal movement. Robot is also good at tying. The right hepatic artery is clipped and divided. The left portal vein is also ligated. After that, peeling group maneuver for right portal vein and hepatic artery, liver transection is started. You can see the MHV in the right portal vein is cut using suturing device. After confirming the bile duct using firefly mode, the left bile duct is cut. After confirming absence of carcinoma in the stump, it is crossed by suture. The procedures are finished. I'd like to talk about 3D simulation system using Synapse Vincent. We can sensorily understand that the intrahepatic vasculature and tumors and remnant liver volume, and the liver function using fusion image with acylglycoprotein receptor imaging. I'd like to introduce further progress novel real-time virtual hepatectomy simulation software called Liversim. The software provided 4 basic functions: doing 3D models from arbitrary directions, changing the colors and opacities of the models, deforming the models based on user interaction, and incising the liver parenchyma and intrahepatic vessels based on user operations. This system helps us to conduct a preoperative simulation in a more similar with the real operation. I will show you the intraoperative navigation. It's still developing technology. Preoperative ICG administration can reveal the tumor even in the case of repeated hepatectomy, especially in HCC. During the operation, ICG administration can reveal the segment using negative and positive staining to be able to conduct more precise operation. Let's move on the second topics. Liver transplant is performed when the liver that play an important role in sustaining life falls into destruction due to many causes. There are 2 types of transplants: living donor and deceased donor transplantation. I'd like to show you a brief history of liver transplant. In 1963, Stadler performed the first liver transplantation. In the first 5 liver transplantation, no patient survived more than 23 days. Roy Kahn, in 1978, used the first-time cyclosporine in liver transplantation patients. In 1984, tacrolimus was found in Japan as immunosuppressant. After that, Stadler used it for liver transplantation, and the outcome have been dramatically improved. In 1990, the first successful LDLT in Japan were performed. In 1993, the first successful LDLT for adult in the world using left lobe graft. These pictures are provided by Professor Nobuhisa Akamatsu from Tokyo University, who is one of my precious friends. You can see the cirrhotic recipient liver, left lobe and right lobe graft in LDLT, and whole graft in DDLT. Recipient operations are done through total removal of the patient's native liver after dissection of the hepatic ligamentous attachments and hilar structures. The inferior vena cava should be encircled to ensure adequate blood control. Donors are either deceased or living donors. In DDLT, whole liver transplantation is more common. The donor's liver is usually prepared on the separate table. And once the recipient body is prepared, the donor's liver is brought to the table, and anastomosis are initiated accordingly. First, the suprahepatic IVC is connected, then the infrahepatic IVC, followed by the portal vein. Once these steps are done, the clamps are removed, and the portal vein initiated the inflow of blood to perfuse the liver. The hepatic arteries of both the recipient donors are connected near the anastomosis, the gastroduodenal artery. After that, bile duct is reconstructed. In LDLT, in the past, living donors were only used in pediatric cases due to the increasing number of patients requiring LT and the shortage of deceased donors. living donors are also used in adults. LT from living donor is more complex and require much careful dissection. Living donor graft is partial, unlike the whole graft provided from a deceased donor. A living donor graft has a noticeably smaller hepatic artery, hepatic vein, and portal vein, which needs to be implanted. So the most crucial part is to make adequate room by incising the hepatic vein along the side to ensure adequate resources for arterial, hepatic, portal, and biliary reconstruction. DDLT usually use a whole liver. The merit is 100% of standard liver volume, but the demerit is longer ischemic time. On the other hand, LDLT always use partial liver. The merit is shorter ischemic time, but the demerit are burden of the donor and concerning of small size graft in adult to adult liver transplantation. You can see the graph of bar graph of worldwide liver transplantation from deceased donor. In Japan, the deceased donors are very small and is ninth from the bottom in the world. On the other hand, in Japan, liver transplantations from living donor are large and is the sixth in the world. You can see the difference with DDLT and LTLT ratio between USA and Japan. I will show you a short video of LDLT performed at Kyoto University. It's provided by Professor Shinichiro Yagi, who is also one of my precious friends. The operator is Professor Koichi Tanaka, who is also the legend of the liver transplantation in the world. There is no difference of the outcome between DDLT and LDLT. The most common cause of death after liver transplantation is infection. These are pictures of post-operative recipient after LT at Canada University. You can see the post-operative smiling recipient after LT. I'd like to introduce recent topics of liver transplantation. Professor Taizo Hibi from Kumamoto University, who is also one of my precious friends, advocated transplant oncology. The concept consists of 4 pillars called as 4Es: evolution, extension, elucidation, and exploration. It's just about broadening indications of liver transplant for non-HCC malignancies. He said that it is their odyssey to redefine cancer care and research, and the concept of transplant oncology. This is a picture of the meeting held in Bali Island last year. Here is Hibi Taizo, Professor Taizo Hibi. In Japan, led by Professor Hibi, multi-center joint research on liver transplantation for unresectable cholangiocarcinoma is being conducted. It's a prospective single-group intervention study to analyze the 3-year survival rate after LDLT for cholangiocarcinoma. Finally, I'd like to talk about the topic of xenotransplantation. Recently, the very exciting news about transplanting a pig heart to a human was launched. Unfortunately, the patient died 2 months later after the transplantation. The concept has problems about not only infection, size mismatch, long-term immunosuppression, but also ethical problems. But it is very interesting and may change the direction of future transplant therapy. In our department, many study abroad doctors have been accepted from Southeast Asia from 2013 to now. At this moment, one doctor from Myanmar is working with us. They are my colleagues. Semoga kuliah ini menjadi jabatan antara Jepang dan Indonesia. Terima kasih atas perhatian Anda. Thank you for your attention.
Terima kasih. Thank you, Dr. Yoichi Kawano. Wow. Such an amazing presentation. It is interesting to hear a great progress in liver surgery and transplantation in Japan. And we really hope that Indonesia can also follow Japan, so our health facility access can spread evenly in all area of Indonesia. And we go to the discussion session. Maybe from the audience would like to ask to Dr. Yoichi Kawano, you can ask directly to Dr. Yoichi Kawano or Prof. Joni. Do you have any question for Dr. Yoichi Kawano, please?
My duty to ask as the first. Thank you very much. It is amazing. I've the first that I saw. That I have seen the operation from the video. I want to ask about the successful of this presentation. In your experience or your colleagues' experiences, how many years that the patients last or can prolong their life? Because in our country, our ex-minister, Mr. Dahlan Iskan, he is also transplanted in Guangzhou, China. Until nowadays, he is very healthy and he feels as young as the owner liver. He's 28 years boy, male, 28 years male. And in your experience, how many years that they have already prolonged their life? Thank you.
Thank you.
In your experience, maybe, Dr. Yoichi Kawano?
Sorry. And
okay.
Okay, thank you very much for your kind question. So So now I'm a specialist of hepatobiliary pancreatic surgeon. I used to do the liver transplantation, but at this moment, our department stopped the program because it's cost it's need a very high cost and need manpowers. So in our department, and we stopped the program. But I used to join to the liver transplantation, and so especially in the pediatric liver transplantation. Yeah, pediatric. Yes, so I think so. That's why. So I asked my friends to ask their sliders. So if you want to see the any liver transplantation in Japan, so I introduce them. So please come to Japan to see the liver transplantation, and so many progressed liver surgery and pancreatic surgery and the hepatobiliary pancreatic surgeries also. Thank you.
Thank you. Thank you very much for your offers to give the opportunity if you come to Japan to ask to see what kind of transplantation you can point it one of the colleges or one of the centers that until now at least in Japan the transplantation of the liver still present. Thank you.
Thank you.
And how about the life expectancy, Dr. Yoichi Kawano? Is there any research for people after transplant, after having some liver transplant, expecting their life for how long, maybe?
And as you know, the liver is a very liver has a the activity to turn over, So at one of my research, so to know we examine, we measure the telomere length, telomere length of the hepatocyte after the liver transplantation. It's one of my research. So and at this moment, it's very difficult to get samples. But so I used to do the research. I reported it. So for the pediatric liver transplantation, so telomere length is shorter in the patient with many complications, but most of them are even and even in the donors. It means that so healthy donors, most of them must be their parents. So I think the life length will be the same as donors or more longer. So many people died caused of no liver dysfunction, the other disorders, and the liver will be live more longer. Can you understand?
Yeah. I can understand it. Okay.
Oh, thank you very much.
Thank you, Professor Chikawano. Maybe if I haven't become ophthalmologist, I will go with you.
Yeah, thank you very much.
Okay.
Welcome.
Because I think we don't have any question. Maybe we can invite our other three speakers, Prof. Joni, Dr. Maki Tobari, and Dr. Ken Sato to in a sharing discussion. Maybe. Oh, okay. Sorry. Dr. Winda would like to ask Dr. Yoichi Kawano. Maybe. Please open your mic. Open your cam, Dr. Winda.
Okay, thank you very much, Dr. Aryani. Konnichiwa, Dr.
Konnichiwa.
Yuchi Kawano Sensei. Firstly, I'm so sorry if my question is basic question because my background is not from surgery department. But I see an amazing liver transplantation surgery in Japan beyond my country. I have two questions. Sensei, is there any special term in living donor liver transplantation surgery, LDLT? Right? Because we know that our cells have limited time to survive without oxygen. And how can we make sure that liver dose transplanting is still alive till the surgery is done in recipient? And the next question is about the xenotransplantation. It's so amazing for me, for us. Have us get the cum test or any procedure before doing the xenotransplantation, Sensei. Arigatou gozaimasu, Sensei. Thank you very much, Dr. Aryani.
Thank you very much for your questions. So, do you want to know the differences that liver transplant and the other liver surgeries? No, I'm sorry. So I can't catch up you. Please, more slowly, please.
Slowly, Dr.
Slowly. Okay. I'm so sorry. About living donor liver transplantation surgery, LDLT, Sensei. Yeah. Is there any special term in LDLT surgery? Because we know that our cells have limited time to survive without oxygen. And how can we make sure that liver dose transplanting is still alive till the surgery is done in recipient patient? For the first question. And the next question is about the xenotransplantation. Xenotransplantation, which is we transplant the animal's liver to humans, right? Have us get the cum test or any procedure before to get the matchmaking the liver of the animal to human. I think like that. Sensei, thank you. Arigatou gozaimasu, Sensei.
Arigatou gozaimasu. And so I'm sorry. So my English ability is not so good. So I think do you know the living donor liver transplantation? No, living donor. No. So
No.
Sorry. So I can sorry. So please.
Maybe
more.
Could she write it down in chat?
Chat. Please. Please write.
Please write down
to the
in the
chat.
Yeah.
Chat.
Okay.
Sorry.
I'll do,
It's,
Sensei.
It's my fault.
Give me
Sorry.
give me more time. Okay.
No, it's
okay. I will write
no
down.
problem. Okay, while waiting Dr. Winda to write down in the chat box, maybe I will invite Prof. Joni, Dr. Maki Tobari, Dr. Ken Sato to join with us, Dr. Yoichi Kawano, because maybe there are some sharing discussion, differences management between Indonesia and Japan. But before that, maybe there is a question that haven't been answered. Maybe we can answer. The speaker can answer it together. The first is, how is the treatment of hepatitis A in Japan? Was hepatitis A in Japan treated with antiviral? Because in Indonesia, the treatment of hepatitis A is symptomatic. Do you want to answer it directly? Maybe Dr. Ken Sato?
Hepatitis A?
Yeah, hepatitis A.
What is your prevalence in your country?
Prof. Johnny, maybe? For hepatitis. Oh, asymptomatic, just.
Yeah, just asymptomatic. If the SGD is not too high. If the SGD is too high, we try to keep the steroid.
Okay.
We usually give them just injection or transfusion, drip transfusion, because the disease is self-limited. So usually the hepatitis A will recover eventually. So there is no specific drug for this disease, I think.
Okay.
Yeah, it's agreed. There's no specific drug. That is why the symptomatic the symptomatic strategy will be taken front of to combat this C virus.
Okay, interesting. So it's the same in Indonesia and in Japan. And the second, are people in Japan routinely given the hepatitis B vaccine or only under certain conditions?
Hepatitis C, right?
B.
B.
Yeah.
Hepatitis B virus vaccine is available.
Okay.
Right? It's also your company, in your company.
Yeah.
In your country.
But we are not routinely vaccinated with hepatitis B. Is in Japan is routinely given the hepatitis B vaccine or only people with under certain conditions?
Oh, I see. I see. Actually, in Japan, universal vaccination had become started in, I think, several years right before, I think. Then less than 1 year, infants or a child can receive hepatitis B virus vaccine.
Okay.
And doctor or nurse or staffs related to medicine can receive also hepatitis B virus vaccine right now. But actually, for general people, the hepatitis virus B vaccine is not available by insurance.
Okay.
Yeah.
Okay. Thank you, Dr. Ken Sato. And the last question maybe, are pregnant women routinely screening test for hepatitis B?
Screening test, you mean?
Yeah, screening test mean
we usually use hepatitis B S antigen, surface antigen. Then we can discriminate whether the people is hepatitis B carrier or not.
Okay.
If they have hepatitis B surface antigen, we should examine further by measuring HBC core antibody, HBS antibody, and so on.
Okay.
Hepatitis B virus DNA is also applied.
Dr. Sato, would you please see the chat? The question is on that.
Oh,
yeah,
chat.
But yeah. I think Dr. Ken Sato already answered all of the question, Prof. Yashiro. It's no problem.
Yes, I know that.
Yeah. Okay, Dr. Yoichi Kawano, have you already seen the chat? The question from Dr. Winda.
Yes.
Yeah. Do you want to answer it now?
Okay. The first one is so it's a little bit different. There is a difference between the Japan and the Western country. So in the Western country, so liver transplantation is very common. for the early, early HCCs, HCCs, and so on.
Mhm.
And so in Japan, the transplant selected almost the last treatment for the patient. It means do you know the MELD score? MELD score. MELD score is the point for the any physical it's one of the diagnoses for the liver transplantation.
Mm.
So in Japan, so it's a little bit difficult. So if the recipient liver is destroyed, worsened, so MELD score is will be up. Then in Japan, the point will be up, and the position waiting for the deceased donor liver transplantation will be up around the MELD score.
Okay.
Okay, so of course, in Japan, deceased donor liver transplantation is very rare. So most of patients died for waiting time. And can you understand? So it's a little bit difficult. If the recipient patient has the healthy donor, so the patient can receive the liver transplantation. But so we have we have a law can perform the liver transplantation under the national insurance system. 3 centimeter and under the 3 centimeter and 3 HCCs under 3 HCCs and 5 centimeter under 5 centimeters or 5 HCCs or under the 500 AFP levels and so on.
Okay.
If the recipient pay the full cost, not without the national insurance, so the recipient will be had the liver transplantation in the most case.
Okay.
Okay, understand?
Yeah.
So, and so second one is let's get
the cum test.
Procedure before doing that. And I'm sorry, I'm not familiar with the xenotransplantation, but so it's my opinion. Xenotransplantation is not common. It's just only the one case.
Still controversial, right?
Yeah. I heard that the recipient accepted the xenotransplantation. It's the test mean the without etiology and so without EBM, so just experiments.
Okay.
So the recipient allow the experiments. But now they develop the, pig liver and so bamboo the liver and so on. So without the without immuno reaction. So I think it's a still researching period.
Questionable.
Yeah, questionable.
Yeah.
I said that, so it's a future transplant, maybe so, and iPS cells, and will act the graft resources in the future also.
Okay.
I think.
Yeah, thank you.
Thank you. Sorry.
Okay, maybe.
Hi, Sensei. I get it. So we can lower the temperature using ice, maybe to make hepatocyte still alive during the surgery, right? And for the xenotransplantation, it's not a common case for right now. But maybe in the next future, maybe we can think about xenotransplantation. It's like that, Sensei. Yeah. Arigatou gozaimasu, Sensei. Thank you very much, Dr. Nash.
Thank you. Okay, maybe Prof. Joni, you have something to discuss to our three. Okay. Okay. Well, okay. I think we already at the end of the session. We already gained our knowledge in liver disease. Maybe Prof. Yashiro, you have something to tell to us?
I don't have any special idea on that, but today I am so happy to hear the special lecture, one from Indonesia and three from Japan.
Yeah.
Okay. Thank you very much for speakers, and especially the moderator, you, Ariani. Thank you very much. Wonderful handling of this discussion. Thank you so much.
Thank you, Prof. Yashiro. Okay. I think it's the end of our session. I would like to show my deepest gratitude to our speakers today, Prof. Johnny Junaidi, Dr. Ken Sato, Dr. Maki Tobari, and Dr. Yoichi Kawano for such an amazing presentations and discussion. We are looking forward to meet you all in person, Doc, Prof, and Prof. Yashiro also, either in Japan or you can visit Indonesia, especially Malang next time. Okay, I'd like to apologize if there are some mistakes during guiding the discussion. Applause for the speakers, attendees, the committee who brought this event successfully. Okay, I will give this meeting to the Master of Ceremony. Wassalamualaikum warahmatullahi wabarakatuh, and see you next time.
Waalaikumsalam.
Bye-bye.
Bye.
Thank you.
Okay, I'm sorry. I will repeat. Thank you, Dr. Aryani, as moderator, and thank you for fourth speaker for amazing and interesting explain and presentation. Ladies and gentlemen, with the end of the discussion session, so we come to the end of today's webinar. I hope today's presentation is useful and adds our knowledge. I represent the committee in charge of apologizing if there are mistakes in pronunciation or wrong action. Thank you to the 4 our speakers, moderator, and committee user, as well as the attention of the listeners. See you at the next webinar. Good afternoon for Indonesian time and good evening for Japanese time. The last word I say, wassalamualaikum warahmatullahi wabarakatuh. Thank you and arigatou gozaimasu.
Bye, thank you.
Arigatou gozaimasu, Sensei.
Arigatou gozaimasu. See you.
Terima kasih semua.
Dr. Lely, makasih dok.
Terima kasih semuanya.